My name is Olihe. I can share with you at least the presentation outline. So what we're going to do in the next 25 minutes, maybe minus 1 or 2 minutes now, is to give you an overview of the distribution of the healthcare workforce here in the state of Minnesota. We will look at some trends over time in terms of racial ethnic composition of our student populations in health professional programs. We will talk about diversity in the healthcare workforce and have some discussion around why that matters. And then we will share with you a strategy that we have put together for a mentoring program towards increasing diversity in the healthcare workforce. Okay, thanks, Glenn. You can advance.
And just so you know, we do have until 2:40, so 35 minutes. But so if you want to leave.
Yeah, I would like to at least have time for questions.
Oh, okay, perfect.
Okay. All right, as long as my audio is still good, then we're okay. Can you still hear me?
It is. You can advance.
Great. All right. All right. I believe I'm not sure what just happened.
I think the host pulled me out and put me back in or something.
Okay.
Yeah, I just found myself there and found myself being put back into the room. So
okay, that was different.
That happened to me too, so I'm not sure what that was about. All right.
So Glenn, if you can share the slides again.
Let's go again. All right, are we back? We're back on the screen. All right.
Well, sorry everyone for the technical difficulties, but we will have this presentation. Okay, so you can advance the slides.
All right, so we've already done some of this outline, correct?
Yes, yeah, so go to the next one. So let's get right into it. So yes, let's look at the workforce. So what we wanted to do was, first of all, just give you a graphic. This is from 2018. It hasn't changed that much, maybe a little bit. Well, it has changed a little bit, but I like this particular graph because it gives you a picture, you know, versus some of the, so you can see proportions just by looking at it. So of course we have a white majority population. Right now, Black/African American is about seven. Then you have Asian, multiracial, and then, you know, just all the other different, you know, racial ethnic populations are represented here. You can advance the slide. So here you begin to see the projected population change. So just explaining this graph, you have this bottom part being a negative change, and then you have the upper part being or kind of increase and then decrease, not negative. I don't want to use the word negative. It's just mathematically, it will be minus. So you have decrease and then you have increases in the populations that are considered minority populations by numbers right now. You can advance. So here we begin to look at, you know, the healthcare providers that we have. So this is the latest data that we have. It was published 2019, but it was from 2018. And so here you can see the distribution of physicians by race in Minnesota. So the first column of data here shows you what we have statewide. And as you begin to look at different parts of Minnesota, you can see that it also changes as you go from one part to another. So some, you know, have higher representation in some race ethnicities, you know, and lower in some, but consistently, of course, you can see that we do have a white majority. And in some of the different regions in Minnesota, you have, you know, really an overrepresentation. You can advance the slide. So here we look at physician assistants, and you can see that it's the same trend that we have here. So you can see an overrepresentation in terms of the majority of the white population, which is in the majority. But this is really an overrepresentation, if you remember from the first slide that we shared. You can advance. This is looking at nursing, and we see the same trend. You can go to the next slide. And this is what we have, with pharmacists. And I just want to remind us again that this is the whole state, but in some regions, actually, like where we are at here in the Duluth area, you actually have it even more so. So I'll hand it over to Glenn to talk about the health professional programs.
Right. And so as Dr. Okoro was indicating, the distribution in terms of the race and ethnicity of the current healthcare providers is such that there's a considerable amount of overrepresentation by some groups, even though the population numbers are slightly different, outside of the workforce itself. And so then as we start having conversations about changing those dynamics to more accurately reflect the population, we start to look at the different training programs that are feeding into this workforce. And so here in the next few slides, we're going to show you basically just trends over the last 5 to 6 years, indicating that even within these training environments that have had these push or these initiatives to increase the workforce diversity, you see that the trends really aren't shifting all that much. So here we have the University of Minnesota pharmacy students, the students that have, I believe this is based on students that have graduated particularly. And so based on race and ethnicity, you can see the upper line, the brown one is the European or white, European ancestry or white students, and everyone else is kind of below there. And you can see, generally speaking, the trends are pretty flat. Whereas I think if you look at this, this green line here, that one actually decreases, and I think that one's cut off, but that may actually be, oh, I can't remember which group that is. That's not native. So that might be the mixed ethnicity or unknown ethnicity. But generally, if you look at each of these different programs, so here's the University of Minnesota Medical School, and this is specifically looking at the Duluth campus because we have a lot more specific numbers based on that from our programs, particularly looking at the Native American population, which is a special emphasis at the University of Minnesota Medical School Duluth campus. And so as you can see here, those numbers are pretty flat in general. And this is total numbers, so this isn't necessarily percentages. From time to time, the Native American or American Indian population within that incoming class does come up a little bit, but it then drops the next year. So it's basically averaging out to about the same over those the last 6 years or so. And then even if we look at the nursing schools, here you can actually see that it looks like between 2019 and 2020, the numbers have increased considerably for some populations, but other populations not so much. So both the white and the Asian American populations have pretty much, had a slight increase or significant increase, and everyone else is pretty much the same. We've also looked at another major health training program, the medical program at Mayo. We weren't able to break out the numbers, so this is actually representing all their programs, but in general, we know that Mayo is also a major healthcare provider within the state, and so a lot of their trainees do end up practicing in the state of Minnesota. And as you can see, even though there is a slight upward trend, that difference between the white student population, this is the incoming class or their freshman classes, it still leaps and bounds ahead of the other groups just based on sheer number, even though there is a, no baby, go back out. Oh, thank you. All right, sorry about that. So we're basically saying that even though we're aware that the population is changing in a very dynamic sense, the reflection of that in the training programs is not really up to par, which means that we have a major disconnect and we have to do something much more dramatic than just saying that we're going to do more about it. And as opposed to that, we could just, maybe think of new ways of envisioning training diverse populations of students in these different programs. And that really brings us to the point of trying to figure out, well, why are we concerned about that? Why does it matter? Hold on one second. Kayan, please come and get him. Thank you. Appreciate it. I'm at home today, so I'm trying my best to be an active father and stay on task. So there we go. All right, so why does representation matter? What's important here? So here we have a case in which a patient is engaging with the healthcare system. They're visiting the emergency department because they have some issue that they know needs to be addressed immediately. It's not just an happenstantial kind of a thing. They know that this is serious. But when they arrive at the emergency department, they don't necessarily get the care that they need. And as a matter of fact, this particular patient states that they felt like the healthcare providers in this situation thought that this patient was trying to get pain meds out of them, like they were trying to somehow get something that they did not need. Now, there's nothing in this patient's history that indicated that this was something that was even a possibility. And in fact, we are sitting in this moment really trying to understand what makes a healthcare provider think this about a patient when there's very little evidence in the records that would indicate that this is necessary. And so in this particular moment, I would like everyone, if you have a moment to access your chat, to maybe just type in your knee-jerk reaction. What do you think? Why would they think that this person was seeking pain meds? What is it that's not present in this particular vignette that would indicate that this person is somehow seeking meds that are not necessary for their treatment? And I'll give you guys like 30 seconds to a minute to maybe just type in a little something there. And Olihe, since I'm kind of on a limited screen thing right now, if you can maybe see if we're getting responses.
Yes, I'm watching the chat. I just want to encourage us to participate, what are your thoughts? Okay, I'm seeing a couple of things in the chat. Right. Thank you so much. So one of it says patient is Black, ED staff is white. Another person says color of the patient's skin. Another one is no history with the health system or lack of regular visit. And so the provider, what I'm making out of that is the provider is going off of what they think maybe. Mm-hmm. Yeah, because they don't have any records. Yeah, and thanks for that. Janelle says, I work at a hospital, and unfortunately that is very real. Because of how they are trained in medical school, concerns about regulatory oversight based on age, racism assumptions. Thank you so much for, assuming persons of color are drug seeking, okay?
Yeah. No, yeah. I mean, all of those comments are spot on in terms of the different types of things that could be playing into the situation. But ultimately, this is something that happens more often with patients of color than other patients, just based off of these assumptions, as was indicated. But we have another word for assumptions, right? And so, Olihe, yes. I'll let you take over from here.
Yeah, thank you so much. So yes, you all hit it right in it. There is, provider implicit bias, and we all have biases. So it's, again, just going back to looking at the population and how a lot of even providers themselves may not have had, interaction with some of the groups that they're providing care for. And it happens all the time, I will tell you. You just have this notions about any population you haven't had much of an interaction with, or you don't know what their life circumstances are or the context around them. And so we have that. And we do know from research that provider implicit bias does contribute to the disparities that we see in healthcare delivery and outcomes. So you have, that. Do you want to go back to the former slide?
Sorry.
Okay. Yes. So you have that impacting just the interaction between the provider and the patient and what that communication looks like. So that happens. It affects treatment decisions. We've also seen that in the literature and just adherence to whatever treatment that was recommended. Quality of care is lower when you have implicit bias, and patient satisfaction with care is less. And all of that affects the health outcomes that we then see, especially with populations of color. You can advance the slide. So what happens? So what we're looking at in terms of, pushing for representation is so that you can have more patient-provider racial concordance. Going back to the data we were showing you, on a state level, persons of color going into the healthcare system are more likely to be seeing providers that are not from the same background, ancestry with them. And so what happens when you have racial concordance, there is a lot of research that shows that it does enhance the patient's experience in healthcare, and that leads to improved outcomes. So there's patient satisfaction, there's better quality of care because needs are better understood and addressed in the context in which they have those needs. There's better communication, and patients typically participate more, and you have more partnership, based on what the culture and expectations are. And it does increase healthcare utilization. You can advance the slides. So why are we talking about adequate representation? Something else that, comes into play is we talk a lot about historical, distrust, and there is contemporary distrust. So not just historical, but what we need to focus on now is healthcare system trustworthiness. How can we build trust as a healthcare system? And so I want to just, point to that sense of ownership that plays into the distrust that we continue to see with communities of color. I do research with communities of color, and consistently in my data, I do mixed methods. In the qualitative data, participants always refer to the healthcare system as they and them. It's consistent all the time. So it's for them, it's almost like the healthcare system is on the other side and we are on this side. So there's that constant reference to the healthcare system as them, which points to that, that there's just a lack of sense of ownership. When you have adequate representation, communities can see their members in that system. They see them as part of the providers, part of the researchers, part of those that teach, part of those that speak on behalf of the healthcare system. When they turn on the news, when they, anything that's going on around healthcare, they can see that they're well represented, and it gives that sense of ownership, which increases trust. When they come into a system and they're able to see others that look like them, they know there are people here who have my perspective, who represent my interest. That's just how it works. And then if you have adequate representation in the healthcare workforce, you just have that stronger advocacy because you have people in the system who have shared life experiences with patient populations that the system is giving care to. And they're not only able to see how the context of the lives of the groups they come from influence or affect health. For them, they're also in a position to affect change because they're at the table where decisions are being made, where policies are being shaped, where processes are being shaped, and they're actually in a place where they can affect change. You can advance the slide. So I want to just, we want to just highlight, structural inequities, because every time we talk about healthcare, what comes up to is that it's only 20%, about 20% of what happens in the context of healthcare, active healthcare itself, that actually results, in the outcomes. So you have a lot more that happens outside the healthcare system, but we do have a responsibility as the healthcare system to engage in addressing what happens outside there, and at the least, be able to make those connections. We call it structural competency. So the questions I would like to pose to us, even as we hear this, is who do you think will understand better the intersectionality of race, ethnicity, and culture with the social determinants of health that play more into the health disparities and the health outcomes that we continue to see right now? It is people who have those lived experiences. It is people who come from those groups, come from those communities that understand the context, the nuances, because it's experiential for them. You can try and teach it as much as you can, but it's just different. Someone gets it when they see it. And so people from different groups are able to make those connections, and then we're able to see how it actually impacts care. We're also able to then engage in addressing them outside the clinic environment. So I would just give you an example. Myself and Dr. Simmons, we have, sat in groups, work groups where something, maybe a process is being shaped, an intervention is being shaped, and once you look at the protocol, something hits you because you understand the community that you come from, and you're like, oh no, this is not going to work. And it's so clear to you, but it doesn't seem to be obvious to anybody else in that room. And you're like, come on, no one thought of this? Why? Because people have blind spots. It's not the context of their lives. It's something that is just not in their radar because they have no frame of reference for that. And so if you have adequate representation, when you're at the table making these decisions, making policies and shaping practices, for all the different professions, and you have people that are representing the different populations that you're going to serve, they'll quickly see it. And not only do they see it, they're empowered to speak up because they're part of the system. And soon enough, they become also they're part of leadership, they're part of policymakers. And so we want that diversity so that people can make those connections, bring those perspectives to the table, and actually be able to affect change. And when you see it and you're from that group, you want to push. Sometimes even if it's not at the level of policy making, like we want it in public health, even if it's just even for the care at that time. I'll tell you a story before I hand it over to Glenn. I was in a group, a couple of weeks ago where there was a nurse, she's Black, and she said, do you think I'm doing something wrong? But every time she's in a place where she's the only Black person, she's a pharmacy technician, sorry. She's the only Black person in that, system. And she said, every time I see a Black patient, I go over and above to help them. And she said, why? Because I've had horrible experiences in the healthcare system and I know what they're faced with. I know what the barriers are. I go out of my way. Even if I finish with work, I will stay on and make sure that they get the care that they need and follow up with them. And she was saying, is that wrong? And I said to her, no, it's not. Because you understand it, you're ready to push. You want to advocate for them. You want to ask whoever needs to be part of that care to engage that you want this person to get the care that they need. So I'll throw it back to Glenn.
Okay, so.
Sorry, I have to share this. I don't know what African country that it comes from. Yes, but truly it resonates with me because the stranger sees only what he knows. You look at things through the lens of your knowledge, and sometimes that knowledge is really very experiential. It's not something you can get from the textbook.
Absolutely. And that's something that we are affirmed or reaffirm every time we do any of our community engaged research, because the conversations that we have, even though we may have similar experiences, those nuances based on geography, based on the times, the time in which I grew up is different than the time that some of the young people are growing up now. And all of those things do play a significant role. And so in order to even start to have this conversation about dealing with helping to diversify these various systems, these healthcare systems, we have to, again, start looking at doing something different than what has already been done. And that's important because myself, I came into programs that were supposed to change everything. Here I am now, a faculty member at a major university, and the system still hasn't necessarily changed dramatically. The numbers are still about as flat as they were when I was a bright-eyed and bushy-tailed undergraduate thinking about what I wanted to do with my life. And so in order to really change these things, obviously mentorship is a very powerful tool in order to help engage young people and even some folks that are mid-career. It's a powerful tool to help get folks involved and to help guide them along the way. However, particularly for communities of color, and specifically when we're talking about African heritage communities, because of my own experience, you have to do things that are culturally relevant, that take into account the reality of the situation of these potential mentees. And one thing I would like to share with you is just kind of my own story. So I grew up in a single parent home from a family that had been mostly military centered for most of my upbringing. And what I would say is that made it very difficult to understand what the educational experience was supposed to be. For me, it was really like daycare in a lot of ways. I would go there while my mother was at work. And that meant that I was extremely isolated when it did come to me advancing my education, because I didn't have that group of peers that I could rely on to help guide me to the next stage. And then also when I did get into the advanced placement courses, when I got into college, I had not had those experiences that actually set you up for success in those spaces. And I struggled tremendously. And it wasn't until I had a mentor literally grab me and say, this is what you need to do. go here? Did things start to kind of fall into place? And then I became surrounded by a community of individuals, both at the faculty level and also these kind of near peer individuals, folks that were just around my same age or maybe older, that were able to help guide me on that next stage. And what we're proposing in the work that we're currently doing now is to take advantage of things that look similar to that, but to do so in a very deliberate fashion, to say that in order for us to get students, young people that are coming from situations where there is one parent or no parents in the household, where money is always a question mark to support their educational endeavors, we have to get them into environments that will nurture them, and not just, oh, we're going to wait for you to get to college and then all of a sudden we're going to throw these resources at you. But you have to start much earlier. You have to give these students the tools. And so we're trying our best to engage students early on in their career. So as early as freshman year in high school, but to also engage their families. And so by doing that, we know that we start to create that atmosphere that's going to be reinforced in the home. And then we also bring in, again, those near peer mentors. So younger college students that can help them translate what that next step is going to look like. Because remember, myself as a faculty member who's gone through graduate school, Ph.D. and all of that, the experiences that young people have today is very different than my experience. I'm not an expert on the youth experience. So that means that we need people that are a little bit closer to where the rubber meets the road. And so the near peer mentors are going to be there. And then we'll have healthcare providers of color that are in the fields that students are interested in, or maybe not interested in, but are willing to give their time and to lend their expertise, and to also allow for that sponsorship. Because what happens a lot of times when it comes to success in healthcare, in these biomedical fields, is that students need to be given resources even when they're not asking for it. And an analogy I like to use when I talk about this is that no parent ever expected their infant child to ask them for the particular type of rice cereal or to get a certain type of food verbatim, to say it literally. They might just make a sound. They may act out, and because you're paying attention that something is wrong. I need to make sure I take care of that. And I think when it comes to these mentorship programs, these different so-called pipelines that exist, we're expecting students to articulate everything way too often and way too early in their careers, which means that only students who've had some kind of nurturing relationships early on in their young student lives will have even the vocabulary to say, I need a tutor, to say that, hey, I would like to go and sign up for this program that will help fund my college career, that will fund my graduate experiences, or I would like to go into an internship. Students of color tend to not have that vocabulary on average. It's not that they're not capable of doing those things, but if their life experiences have them focused on other things, like surviving in environments that are a little less than safe, then you have to understand that they're not going to be ready to articulate things that are at a different, kind of from a different life, a different sphere. And I think it's important to have sponsors as well as these role models and mentors to kind of make sure that the students are getting things that they're not asking for. And then they'll also have things that are kind of the obvious coin of the realm, to give them the research experiences, the tutoring opportunities, as well as the networking opportunities that will get them in the door so that they can move themselves towards success. And so for myself, I am a product of pipeline programs. And I know that had it not been for really strong mentorship early on, I would not have made it to the end, because many people that I grew up with in science did not make it to the end. And that is not because they lack the skill, but it's largely because they lack the ability, or they lacked the access to the networks of individuals that could help empower them even when it got difficult. Because when we are going into these spaces of higher education, they are often there's either benign neglect or there's antagonism, because being different does not always work in this space, especially in something that is as challenging as increasing the body of knowledge in any field of human endeavor. And so I would say that our program is designed to not just start mentoring, but is to continually mentor for the entire time that a student is willing to be mentored. Similar to myself, I still am mentored by my mentors from college, from my postdoc, and from graduate school, because mentorship is a lifetime commitment until there's something that's actually known to be wrong in that relationship. But it is, in fact, a relationship, and we treat them as such in order for the programs to work for the populations that we're looking to work with. So, so with that, I think we can kind of maybe wrap it up and open things up for questions, because again, we're really interested in hearing thoughts from other folks, but we have been doing this work, we've been on the ground, and we've seen that even though some of these programs do work, we get people to the other side, we have to do something different, because far too many people are not even engaging in healthcare. They're basically not participating, and then they don't want to engage even as consumers of the healthcare system because of the experiences that they see being on the outside looking in.
Thank you so much. And so this is Annie. I'm just going to hop in so we can have a few minutes for questions and maybe some dialogue as well. So thank you for this presentation. This has really been informative and thought-provoking. I know there was a question earlier in the chat about why is full funding for students of color not already something that, you know, that some higher education organizations why is this not happening? And I also have a similar question. I see that you titled this a proposed mentoring program. So I'm wondering if this is something where you're still seeking funding, and it's, I guess I'm kind of getting to what's the institutional support for this, and what can public health advocates like us do to help move something forward along these lines?
Yeah, thank you for that question. Yes, it's proposed because it's something we're still seeking funding for. And sometimes the problem is that sponsors have not, seen the value and significance of this, because sometimes they're like, so what's different? There've been pipeline programs, but these are elements that are so key, the intentionality about those connections, and just to echo what Glenn said, it's a lifetime thing. It's the way communities of color mentor, I would just be frank with you, is different. It's different. It's not about having an academic advisor. It's different because it's more holistic, and it's speaking to context, and there are nuances to that. I would say even for myself, my mentor still mentors me even up till now. And this is like 7 years, graduate studies. Just a few months ago, she's emailing me, oh yeah, I'm leaving this position. Are you interested in it? She immediately thought of me. That's what she was thinking. I'm like, I'll pass on this one. Yeah. And she constantly does that. Even if I haven't spoken with her in a while, she would see something and she would do that. And so it's something that requires a bit more. It's not just having a pipeline program. It's more than that.
Right.
Yeah, and
to the question of what can well, if people are willing to sponsor this, we're open to moving forward with it, because we want to get this done and ensure that it's sustained. We just don't want to do a one-off 1 year thing or 2 year thing, and then the students are in college and they can fend for themselves. No, it's something that needs to be consistent, and we have to keep making those connections. And we see it very necessary here in Minnesota and where we are at, because the Black scientists and health professionals are not that visible because they are very few. I will tell you, my children have been in public school here for 7 years. They've never had a Black teacher, ever. In the 7 years they've been in public school. So there's nothing in front of them. Same thing with healthcare. Their pediatrician has always been, a white person. So where's the modeling? Who are they seeing? Who is before them? So we have to be intentional at connecting those so that these kids can actually see there's someone like me who is a researcher. There's someone like me that can go into the labs and see experiments being done. And we've done this just on a one-on-one. There's a student in the pharmacy school right now that actually walked in Glenn's lab, and so could see himself in that. And now he's in pharmacy school and so, inspired and wants to move on. He didn't come into, undergrad thinking all of that, no, but he got opportunity very intentionally. We've been able to kind of do that. So they can see other people and they're like, I can be all that. And we'll continue to hold his hand through the process, and hopefully, he will get to where he needs to get to.